Healing Hands Health Society presents Dental Webinar Series. We have planned a series dental webinars to keep you abreast of current practice. This series on prosthodontics will be via Zoom, Facebook Live. Presenters are drawn from dental schools in the USA, private practitioners from around the world. To register for future webinars, visit www.hhands.org/dental-training. For future inquiries, contact Facilitator.
Completed his dental school in Brazil in 2011. Afterwards, he worked in private practice and the public sector for about 2 years before engaging in a specialty degree in prosthodontics in the Brazilian Dental Association, his hometown. In 2016, he started a master's degree and residency in graduate prosthodontic department at the University of Michigan, United States. His master's degree was completed in 2019, in which he had an opportunity with world-class professors providing different perspectives in dentistry, especially prosthodontics. Also, he has had an opportunity to work with different new technologies, developing a passion for digital dentistry in the process. Right after the residency, he's had to work at the Ohio State University as an assistant professor focused on the education of the new generation of dentists. Dr. Diogo, it's a rare privilege to have you here. I happen to be seeing some of the patients that you saw back at the University of Michigan. You know, everybody has very good things to say about you, but thank you for your willingness to participate in this webinar series. Please take it away.
Thank you. Thank you. Thank you very much to be here. Okay, let me start sharing my screen. Can you hear me clearly?
Yes.
Perfect. So, okay. So yeah, that's actually really interesting, the way that we end up matching, because Dr. Saad did discuss all the treatment planning aspects on implant dentistry, and I'm gonna go a little more towards the dental material and the options that you have once you've done all the treatment planning part that Dr. Saad discussed. So if you are a dental student, these probably will have some new information for you. If you're a dentist or a prosthodontist, I would think that these will be mainly a review. So let's go straight to it. Dental ceramics, in a way, is you have to understand the material that you're working with, because if you don't understand the material that you're working with, you can't really restore a case as complex as this one that we're starting. We have different backgrounds, and within different backgrounds, if you don't understand the physical properties, the mechanical and the optical properties of the material, you won't be able to deliver a case with excellency. And I hope that at the end of this presentation, we will have a better grasp on what to select and how to select and why we're selecting it. Before we talk about ceramics, though, we have to understand why ceramics is as important today and why it wasn't as important as it is today in the past. So you have in perspective, and those numbers, again, keep in mind that I'll reflect the numbers in United States, because this source of those numbers are from the Lab magazine today, which is a dental technician magazine. So in 2000, the dental technicians manufactured 80% of all the restorations being metal ceramics, which is you have the metal infrastructure and you have the porcelain on top of that. And only 20% were metal free. And by metal-free, you can have a complete ceramic, a layered ceramic, or even a polymer type of restoration. So if we fast forward to 2015, we see a paradigm shift from 20% in 2000 to almost 61% in 2015, and only 39% at that time being metal ceramics. If we fast forward a little bit more to 2017, now we have the complete paradigm shift from the opposite scenario in 2017 when you compare it to 2000. So we have 84% of all the restorations now at this point being metal free, and only 16% being metal ceramic. So when we see a situation like that, you have to ask yourself, why is this happening? And to answer these, we have to understand what the metal ceramic means and what this kind of restoration represent. If we observe the systematic reviews that the metal ceramic have to show on the literature, you will see that single crowns have a survival rate in 7 years of 96%. And in 10 years, we have 90%. The most common biological failure, the most common failure types that we have with the metal ceramics are biological or mechanical. Biological meaning secondary decay, and mechanical meaning either porcelain chipping or the design of the restoration wasn't optimal to begin with. So when you deal with these numbers and with these kind of failures, we have to ask yourself, was it really the material that wasn't successful? Was it really the material that needed to be changed in order to fulfill the requirements that our patients have? And the answer is most certainly not. This is a diagram that I like to think and I like to present to my students. If we have in one side, in here, one dentist sending his crown and his works to the dental laboratory, and this laboratory goes through the conventional workflow, providing, let's say, metal ceramic crowns and metal ceramic restorations. If we send in today, and the lab technician A is a really skillful and talented lab technician, and he can provide you a really good looking restoration, in a week from now, if you follow the conventional workflow, there's a chance that lab technician A won't be working for you anymore, and lab technician B is not as skillful as lab technician A. Therefore, your crown won't look as good as it looked before. If we look at the scenario here in which this lab now works using the digital workflow, you don't need to be as talented as your neighbor dental technician to provide the same quality of restoration, because the digital workflow enables you to get this standardization of the restorations. That being said, a paper by the Switzerland group, Dr. Saylor, showed that the time needed to fabricate one restoration from impression to cementing is decreased using the digital workflow. What that means is that for the lab technician perspective and for the dentist perspective, it makes more sense to use the digital workflow rather than the conventional one. So now the whole picture is making sense. Again, the same source, we can see that CAD-CAM mill restorations went from close to, let's say, 5–10% in 2005 to almost 70% in 2017. And again, Using all ceramic restorations, you can go throughout the whole process using the digital workflow. Whereas with the conventional metal ceramic restorations, you can still go through the digital workflow, but you still need some analog work. You still need to, if you mill the wax, you still need to cast that and to invest that, and then you have to apply the porcelain on top of that. So the all ceramic is linked directly to the digital dentistry workflow that we see nowadays, and is getting popular and popular. So again, if we go back to that case, and the reason I like this case is you have a lot of different backgrounds there. We have cast, post, and core. We have full contour crowns. We have veneers, and we have implant restorations. You will never be able to deliver the good result if you don't understand the optical and mechanical properties of the ceramic material that you're selecting it. So if you are a dental student, you have to understand and to appreciate the importance of knowing why and what ceramic will use in that specific clinical situation. If we got now in one graph, in one axis we have translucency, and on the other axis we have strength, of course, ideally, we would go for a material that is high translucent and it's high strength. Unfortunately, that material doesn't exist. So if we were to put the metal ceramic restoration in this graph, it will be located kind of halfway there. We don't have a lot of translucency because of the metal coping. We have some strength, again, because the combination and the years of experience that our lab technician and we as dentists have with the material, but it's far from the ideal scenario. And now we have to think on where we're gonna locate the ceramic materials that we have available. And to be able to locate and to discuss these materials, we have to classify it. And the classification can be based in 100 different parameters. You can base it in the clinical applications, you can base it in the fabrication method, and you can base it in the microstructure of the material. Dr. McLaren, even though the classification of Dr. McLaren is from 2010, it's still really updated on what kind of material we use in a different clinical scenario. Even though we don't discuss the crystalline phase or the microstructural features of the material, that guide us to what material we use when and where. And we can divide the material base in basically 4 groups. We have the glass base, we have glass base with fillers, we have crystalline base system with glass fillers, and we have the polycrystalline solids. Since we don't use as much the glass base and the crystalline base system with glass fillers, we're gonna discuss today mainly 3 materials: the feldspathic glasses, the lithium disilicate glass ceramic, and the polycrystalline solids, which is the zirconia. The first one is the feldspathic glass. What you will see is that mechanically it has the flexural strength of 60 to 100 megapascal, which is really not a lot. The composition of it has a glass matrix based on feldspar, and we have crystals of alumina and silica. The important aspect here is the manufacturing process. To manufacture a feldspathic porcelain, we have to go through refractory dye, platinum foil technique, or you press it. But what you appreciate in the following pictures is that it is extremely technique sensitive. You can get to optimal results, but it is extremely technique sensitive. Since you using a material that is 60 to 100 megapascal, you are relying on the bonding of this porcelain to the tooth. So you have to follow the guidelines to be able to provide a good bonding of the ceramic to the tooth. But again, you can achieve excellent results with it if you know how to use it, and especially if your lab technician is able and willing to work with. I'll be completely honest with you. I finished my pros residency in Michigan, and I tried a few times to work with feldspathic porcelain, and it's just really hard to find a dental technician that is willing to work with the feldspathic porcelain. See how thin this porcelain fragment is. It is extremely frustrating to get to the point to cement, and these porcelain fragment fractures while you're trying to do that. And then you have to call your lab technician and tell them that something went bad while you were trying to cement, and he has to do a new one. And remember, since this is all hand skill based, you won't have two identical porcelain fragments. So the lab technician will have to go over and do it. Those pictures are from William Geller. He can do those kind of things, but not all dental technicians will be able to do it. That's why it's not widely popular. That's why it's not commonly used, even though you can get excellent results within it. And then if we have to locate the feldspathic porcelain within the graph, you will locate it. It is high translucent, but not as strong as you want it to. If we move forward to the lithium disilicate glass ceramic though, now we have 70% of the whole material being filled with lithium disilicate crystals. And then it makes the mechanical property to jump to from 100 from the feldspathic to 450 megapascal of flexor strength. And why is that? Why the lithium disilicate is not as translucent as the feldspathic, and why is it the 70% of the lithium disilicate crystals make it so much stronger than it? And the answer for the first question is the transmission of light. We have the light transmitting in the case of the feldspathic porcelain almost going through and through, which makes it being the definition pretty much of translucency. The light comes in and it just a small portion of it deflects, but the most part of it just passes through. For that reason, it's seen from us as being translucent. If we imagine that here in gray we have the glass face and in blue we have the crystals, now the light comes in, bounces on the crystal and deflects. It goes through, but you don't see as translucent as you see the feldspathic porcelain. However, when we translate that to mechanical properties, it plays the opposite role. Now you have a crack line that can cause, in the case of the feldspathic porcelain, on the lithium disilicate, you need a lot more energy to this crack line to propagate through and through and to cause the catastrophic failure of the restoration. That's why we had from 100 from the feldspathic now to 450 megapascal on the lithium disilicate. if we discuss and if we were to understand how we can manufacture those restorations, it can be pressed and it can be milled. Pressed will resemble a lot on the process on how you get to the metal ceramic restorations, for example. And the milling process, you're gonna have a little block of the material and you're gonna carve out of it. And either option, it can be monolithic or it can be veneered. Milled, it can be monolithic and it can be veneered. For those of you that are not as familiarized with term monolithic and veneer, monolithic, when we say monolithic, we mean that you have one block of material and it's only that block carving out of there the whole restoration. So you have no layering to it. When we call veneered, we do have the same infrastructure, but now we have a cutback in which you will apply the veneer material or the layer material. So that's why we call veneered or monolithic. If we go to the literature and take a closer look on the numbers and the survival rate and the success rates of this material, you'll see that in 2 to 5 years, single crowns, it has 97, close to 90%, let's go if we average all the studies, of success rates. And that, for me, it's a great result. And the literature shows really good results within the lithium disilicate for single crowns. When we go for FPDs or fixed partial dentures, the success rate decreases dramatically. And you have to understand the indications of the material. Lithium disilicate, according to the manufacturer, is not supposed to use in the posterior region of the mandible and the maxilla. The mechanical properties of the material do not allow you to do that, even though we do use it in some situations. But the manufacturer does not recommend you to do that. And that's why in some of those systematic reviews, some of the randomized clinical trials, it was used lithium disilicate on the posterior area of the mandible and the maxilla. So that decreases the survival rate of the material. But still, for single crowns, we have an excellent survival and success rate. That's why it is widely popular in the United States and in the world. If we put that in a graph, we can appreciate how much success are we talking about. And then a quick case, just so you guys don't fall asleep. This case was done in the University of Michigan while I was a resident. The patient came in with a fractured tooth number 8, or you and the rest of the world call number 11. It was actually sent from the endodontist asking to extract number 8 and place an implant there. So we did a mock-up and explained him that he had several diastemas all around. We extracted tooth number 8. We placed the implant immediately with a soft tissue graft and a bone graft filling the space between the alveolus and the implant. And we did prep the teeth. This was the healing of the provisional. Since we used the shape of his own tooth as a provisional, we got a really good architecture, and we were able to preserve the thickness and the buccal bone of the most part of the buccal bone in the healing process there. This is impressions. This is the material. We did these in Emacs, and because it's Emacs, remember that you have the glass phase, so the bonding process involves treating these glass phase to create these intricate bonding with the tooth structure. And this is the final result. Patient was extremely satisfied, and this is 1 year follow-up from the delivery. So we see the soft tissue healing amazingly well, and the soft tissue health responding as good as we hope for. So if we were to locate the lithium disilicate within the translucency and strength graph, it will be, again, almost in the center of it, because we have some translucency because of the glass, and we have some strength because of the 70% of crystals. So within the lithium disilicate, you still have different options of translucency, and they are, again, directly related to the strength of the material as well. And then it comes the polycrystalline solids, which nowadays is one of the most popular ceramic restoration options that we have in the United States, and is becoming widely popular in the rest of the world as well. I'm not going to discuss if zirconia is a metal or not, but yes, zirconia comes from zirconium, that is a metal in the periodic table. But it has all the mechanical and optical properties of a ceramic. So I would like to call it a ceramic, even though it comes from a... So let's discuss now the composition of it. And this might be the most important slide from the whole presentation when we talk about zirconia. Because zirconia, again, is getting widely popular, we have to be extremely cautious and attentive when we were to select and to work with the material. The zirconia has 3 crystallographic forms. We have the monoclinic, we have the tetragonal, and we have the cubic. Forms is stabilized, is stable at one specific temperature range. As you increase the temperature from monoclinic to cubic, has a difference in volume. So cubic needs more temperature, it has lower volume. Tetragonal, less volume and less temperature. And monoclinic, less temperature and more volume. So this transition from one crystallographic form to the other one changes 2 parameters, temperature and volume. And that's really important for you to understand, so you can understand the clinical applicability of the material. Since the material itself is not stable in room temperature, the manufacturers added elements to the zirconia itself. That's why we call zirconia is not a pure zirconia, it's a zirconia alloy, because we have, for the dental application, the yttria that is added to the zirconia to stabilize it in the specific crystallographic form that we want. The traditional zirconia is stabilized in the tetragonal phase. And one thing that is extremely important as well to understand is that zirconia has no pattern within the material itself. We don't have a patent to the zirconia, like similarly from what happened to lithium disilicate. Lithium disilicate is known on the world as Emax because Emax hold the patent for the lithium disilicate for a long time. Zirconia has a no patent within the material, which means that you can have, and literally you have, 200 different zirconias. That's why it's important for you to understand the crystallographic and the mechanical and optical properties of the material, so you can select the specific one that you know is going to behave predictably the way that you want. That being said, recently, and when I say recently, is recently scientifically, which means 5 to 10 years ago, the manufacturer developed what we call translucent zirconia. And what they did was they increased the amount of vitrea within the zirconia to close to 5 to 8%. And instead of stabilizing the zirconia in the tetragonal phase, now you stabilize it in the cubic phase. However, they lost some of the mechanical properties, and the flexural strength of the material dropped from 1/3 to 2/3 of the conventional zirconia. And you understand why right now. The conventional zirconia has a flexural strength of almost 1400 megapascal. Now remember that the lithium disilicate had 450. We're talking about almost 3 times that number. Actually, almost 3 times that number. The translucent zirconia has 550, a little bit over the lithium disilicate. So then comes the question, why do we have this difference if they are basically the same material? And the answer is transformation toughening. Transformation toughening is a phenomenon that the zirconia go through, that if we simulate again the same fracture line, and by this diagram here, what I want you to see is this is all the zirconia. Since we don't have the glass, we have a lot of crystals. They are intricately close to each other. If we have one stress or an energy that is applied to this material that is enough to create a fracture of the material, this energy that is applied to the ceramic that can cause fracture also cause the transformation of the crystallographic phases. So within the boundaries of the fracture line, you have the transformation from the tetragonal phase that it was stable at to the monoclinic, which caused literally a healing process of the fracture line. So then you ask, okay, now we have the tetragonal phase transitioning to the monoclinic, and that caused the healing of the fracture line. But then why we don't have that with the translucent zirconia? And the answer is, again, remember that the translucent zirconia is stable at the cubic phase, not the tetragonal one. Because of that, the cubic cannot transform into the tetragonal, and then it cannot transform into the monoclinic. For that reason, you don't have transformation toughening happening with the translucent zirconia. So that explains why the translucent zirconia is 1/3 of the strength of the conventional one. The manufacturing process, however, is similar to all of them. All of them will be milled or carved out of a block, and it can be, again, monolithic or veneered. One thing that I have to point out and you have to understand is that since zirconia was known as an opaque material until they introduced the translucent zirconia, most of the zirconia restorations that were placed past 10 years ago were veneered. You were doing the infrastructure in zirconia, but you were veneering the porcelain on top. And that will explain the failure rate and some of the literature on the zirconia restorations. They were published until 3-4 years ago. When you're reading about zirconia, we have to be careful on what type of zirconia is being discussed and what type of restoration is being discussed. The adhesive protocol to the zirconia, since we don't have a glass phase, is somewhat controversial as well. It is proven in the literature that you can find and you can achieve a good bonding to the zirconia by applying an air abrasion to the intaglio, or the internal aspect of the crown, within the use of an MDP cement, or a cement that has MDP within it. And that can achieve a good and predictable bonding to the zirconia. However, in the long term, there is no randomized clinical trial showing that the bonding is reliable and predictable in the long run. So that's why the adhesive protocol with the zirconia is somewhat controversial still. Some of the interesting aspects of the zirconia as well is that there is a misunderstanding of what hard and strength means. Some people understand and think that because the zirconia is hard and has a high strength, it will cause wear on the antagonist. And that's not what the literature shows. The literature shows that the wear of the antagonist with the zirconia that is glazed and polished is actually just as good or better than the other ceramic materials. And again, when we look at the failure modes, we have the most common fine failure mode with the zirconia in the literature being chipping of the veneering porcelain. But now that we have a monolithic restoration, there is no veneering porcelain chipping. There is also discussed in the literature what we call low temperature degradation, which is the material transforming from the tetragonal to the monoclinic phase in room temperature without stress. And that could lead to decrease in the strength of the material itself. However, all those studies as well showed that it is not clinically applicable to think on the low temperature degradation of the material as being a limitation of its use. And the survival rates of the papers that we have published are pretty high, 98 to 94% in 3-4 years. So it is a viable option if you understand the why you're doing it and how you're doing it. This article from the group from Alabama, just published 2018, evaluate flexural strength with the 3-point bend test. It evaluate the translucency and evaluate the bonding to lithium disilicate, translucent zirconia, and conventional zirconia. And the results summarize what we discussed. When we talk about flexural strength, we have conventional zirconia significantly stronger than the high translucent zirconia, which is again significantly stronger than the lithium disilicate. Whereas when we look at translucency, we have lithium disilicate that is a lot more translucent than the conventional zirconia and the high translucent zirconia. And the bonding and the wear pattern of those three materials are fairly similar. Again, this is an in vitro study, so some of these numbers have to be carefully evaluated when you're translating that to the clinic, but it shows a pattern on what we see in the clinic as well. So again, if we put all the materials in the graph, you have to understand when you're using what and why for which specific situation. What do you need? What's your substrate? What do you have opposing it? What kind of translucency are you looking for? Can you achieve a good bonding to the material? Can you not? So those things have to be all balanced and carefully examined to achieve a result that is predictable. And that's why I hope that now you can understand a little bit better that all these materials, they have a place within this graph. And based on where they fall, you can select the exact and specific clinical scenario in which they best can be applied on. And that's it, what I have for today. If you have any question, I'll be more than happy to answer those. Thank you very much for your attention, especially today. It's 4th of July here, so happy 4th of July for those of you here in the United States. And happy 4th of July for those of you that are not as well. Thank you.
All right. Thank you. Thank you so much. This is a very, I think it should be in your reference section every time you need to go back. And we're going to have a part 2 of this ceramics by Dr. Cortez. Is going to be giving us a second portion of this. But I think it's something we need to review. I have a post-test for today. So I'm just going to launch that post-test, allow people to attempt to answer the questions. Then you would go over the questions again, over the answers. So let's take. You probably have to read a little bit. I'm going to give you let's give ourselves 5 minutes. I'm going to launch the poll. Let's find it here. I'm going to launch it. It's going to take probably like another maybe 4 or 5 minutes for you to read through and make the right choices, or whatever you think the answers will be. Then we would go through. Dr. Diogo is going to go over the answers. Okay, I'm launching it right now.
Cool.
So take your time. It's going to take us, let's take 5 minutes. I'll give us 5 minutes to answer the questions. Some of you might finish much. It's just 5 questions. Go ahead and I'll jump in afterward. We're almost halfway done here. 27% of us. Please go ahead, answer as much as you can remember. So there's a lot of information.
I did get one question here, Uvo. Can I?
Yeah, go ahead. Yeah, why did? Go ahead.
So it asks, do the manufacturers indicate which phase their products are sold in? They do not necessarily. So that's why it's important to know the kind of these physical parameters within it. So if you see that the manufacturer says that you have 8% mole of yttria within it, it doesn't really matter what do they say. You know that it's stabilized within the cubic phase. And that's a great question for different reasons, because what we see is that we all want, again, the ideal restoration is the one that's strong and translucent, because that will mimic the tooth structure the best. But then, again, because all the dental professionals want the restorations to be translucent, all the manufacturers are pushing for that. So you can have a material that is not translucent. It is the conventional opaque zirconia, but it's called translucent zirconia. And you have the new generation of zirconia being called high translucent zirconia. So the way for you to tell is, again, go on the crystallographic form of it. If it is stable within the cubic phase, you know it is the true high translucent zirconia. If it is 2 to 5% of yttria, you will have the conventional zirconia, which is not expected to be as translucent as everything else. So you have to know these crystallographic parameters to be able to answer and to select your material that you're looking for. Because sometimes not even the lab technicians know those answers.
All right, I'm going to end the poll and allow you to go through. I'm going to share the results. Okay, go ahead, Doctor. Can you see the responses?
Yeah, I can. Absolutely right. Yes. FELDSPATHIC is, as we discussed, the best from the ones that we discussed with the best translucency. Transformation toughening is exactly going from the tetragonal to the monoclinic phase transformation. So FELDSPATHIC glass is more translucent, but it lacks the strength of the lithium disilicate. And according to the current literature, the highest failure rate experience with zirconia crown is chipping of the zirconia material with the veneer porcelain on the zirconia. So if the zirconia is glazed and polished, it is unlikely to wear the antagonist. And the zirconia, it shows the best and the greatest flexural strength. One thing that is, Uvo, that is interesting about those questions is that I took those from my class that I teach on the Ohio State. I asked the students to create questions, so that I took those questions from them.
Oh,
so it's
wow.
a great thing that I could use, and I could get the similar response from these audience, the same ones that I got from them. It shows the level is somewhat the same. It's reassuring and good to see those things.
Okay. Anyway, thank you so much. This recording is going to be available on YouTube. I think you want to go back and take some notes, because this is especially, getting used to this these materials is something we use on a daily basis, and having to understand the way the properties, physical properties, is key in the outcome, because you need to know what the material can do and what it can show you or give to you. You're talking about outcomes. It's not just your own portion. You've done your good dentistry. There's a lab, there's a material. There's so many factors that come together. Dr.
Healing Hands Health Society presents Dental Webinar Series. We have planned a series dental webinars to keep you abreast of current practice. This series on prosthodontics will be via Zoom, Facebook Live. Presenters are drawn from dental schools in the USA, private practitioners from around the world. To register for future webinars, visit www.hhands.org/dental-training. For future inquiries, contact Facilitator